Okay, we're recording. Okay, let me be a professional. Okay, so we'll start this over. My name is Tina Sidden. I'm the Program Director of the Respiratory Care Program. I've been asked to talk to you all about mechanical ventilation and respiratory care as far as pathophysiology for respiratory diseases. The first thing I'm going to start with is introducing you all to mechanical ventilation. Okay? Oftentimes, when you first see a mechanical ventilator, when you walk onto a CCU, it's very overwhelming. 9 times out of 10, that pretty much means the patient's extremely critical. Okay, so you need to bring your A game, you need to bring your critical thinking abilities. What we're going to cover today are some basics of troubleshooting with mechanical ventilation, as well as discussing some ventilatory strategies related to some of the disease processes that you all may have already covered. Okay? So to get you started, any time that a patient is on mechanical ventilation, as far as just basic mechanical ventilation, you are always going to have the following settings. You're always going to have a tidal volume. Normal tidal volumes will range quite greatly depending on the age and the height of your patient. I don't know if you're aware, but we do not ventilate patients based on their body weight. Okay? Our lungs match what should be our ideal body weight, which is based upon our height. Okay? So the shorter we are, generally the smaller our tidal volume will be. The taller we are, the greater the tidal volume. You have to remember that, because if you are caring for a patient who is overweight or obese, it would be a mistake to up the tidal volume because their lungs don't grow as we gain weight. Okay, so tidal volumes commonly for most adult males and females will run anywhere in the 500 to 750, sometimes 800 range. That's a very common range for most average adults, average adults who do not have any significant lung disease. Okay, this number is going to vary depending on what form of lung disease your patient has. For example, I think Marcia showed me your PowerPoint, and didn't you guys cover ARDS? Okay, what happens to the lung with ARDS? Who knew I'd be asking you questions? Now you're on the spot. It's okay, you can look through your notes. I'm pretty sure she told you. Very good, so we have some swelling. Great job. I'd high five you if I could. Okay, anybody else? Your breath sounds may not be abnormal. Most commonly, they're going to be maybe bronchovesicular or diminished. What I'm looking for, folks, is do your lungs get stiff or do your lungs get floppy? Somebody said it. Yeah. Stiff. Okay. When we ventilate stiff lungs, that's considered low compliance. Okay. When you ventilate stiff lungs or lungs with low compliance, you have to decrease your tidal volume. This is going to seem really silly to you, but you're going to remember this, I promise. I want everybody to put your hands up like this. Awesome. Okay? Now, what you are doing to your patient if you give them too large of a tidal volume is effectively this. Everybody clap 10 times as hard and as fast as you can. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Look at your hands. They're red. What do they feel like?
Tingly.
They're tingly. What else are they? They sting. What else do you feel? Do they feel a little swollen maybe? Okay. Every time you take someone with low compliance and you force a large tidal volume into their alveoli, you stretch that alveolus, and because they have low compliance, the alveolus slams shut. What you feel on your hands is what is going on in their lungs. You all were telling me, this nice girl back here said there's some swelling. Definitely, your hands feel swollen. You have to remember that your alveoli are tissue paper thin. Now, can you imagine holding Kleenex in between your hands and doing those 10 claps. What are you going to do to that piece of Kleenex? You're going to tear it. So you have to be really careful if you have a patient with ARDS to make sure that the tidal volume is appropriate for their height as well as their disease process. Because imagine, we also set a respiratory rate. If I set it on 20 breaths per minute, which is normal, 20 times a minute, 24 hours a day, for however many days they're on the ventilator, I am doing what you felt with your hands. What do you think that does to the lungs' ability to exchange gas into the teeny tiny capillaries? It decreases diffusion greatly. And what is very frightening with ARDS is if we are doing that, your patient can have chronic lung disease afterward. Okay? So I share that with you, A, because it's a disease process you're learning about, and B, because sometimes when you feel something, it makes you remember it, okay? And you'll be very aware if you work on critical care. So that's tidal volume. We talked about rate. Your rates for mechanical ventilation can go just like your rates when you breathe, okay? Anywhere from 12 to 20 breaths per minute is normal. The breath rate goes down as the patient becomes stronger and their disease process resolves. Who can tell me why we can take the breath rate down on a ventilator when somebody's disease process is resolving?
Because they're breathing on their own.
They are breathing on their own, and we want them to have that work, okay? All right, so that's tidal volume, that's rate. The next setting that you will always have is FiO2. We can range anywhere from room air, which is 21%, all the way up to 100% oxygen. Okay? That is going to vary, once again, based on what is going on in your patient's disease process. The other thing I want to talk to you about is PEEP. Have you guys covered PEEP? What is PEEP? Other than something that's really yummy you eat around Easter, the little yellow barb-looking things. What's PEEP? Very good. Why do you use it? Okay, I'll cover that.
I said you cover it.
That's in my bag of tricks. I'm good with that. Okay. The reason you use it is to recruit the lung to improve your patient's oxygenation status. Recruit the lung to improve your patient's oxygenation status. So here is what happens with some disease processes. We can put this ventilator all the way up to 100% oxygen. But if the patient's alveoli are collapsed, is the oxygen going into the unit that can diffuse it into the blood? No. So positive index Vittori pressure is a continuous pressure that goes down through the tracheal bronchial tree all the way down to those little alveoli and pops them open. And amazingly enough, when we get the alveolus open, now where can the oxygen go? It can go into the alveolus and it can functionally diffuse into the capillaries. And then the heart, the kidneys, the liver, the spleen, the intestines, they all get oxygen. And remember that oxygen is food for the body. So it's really important to get those alveoli open. Okay? So those are your basic settings, other than if you'll take a look up here at the top of my screen, and I apologize, I'm not sure how well you all can see it, I have something called the mode. The mode means, how are we going to control the breath? Is the machine going to be in complete control? Is the patient going to get to choose when they take a breath? There are modes that are combinations. And what you need to know is that if you are ever in question as to your patient's ability to sustain their own respiratory rate and tidal volume, use full ventilatory support. And the mode you will most commonly see for full ventilatory support is assist control. It's written on this vent as AC. Okay? AC guarantees that every single breath, My patient is going to get the tidal volume that I say they should get, and they're going to get the number of breaths that I say they can get. So if they become apneic, not a problem. This vent's in complete control. That brings me to, I always talk to my students about our friends, our nursing friends at the bedside. You all get to give these wonderful sedatives. Wonderful things, especially if you are mechanically ventilated. Sedatives such as Demerol, okay? Propofol, have you all covered Propofol? Okay, Propofol is a very heavy sedative. We use it a lot for critically ill patients. One thing you need to know about Propofol is as you titrate Propofol up, your blood pressure is going to drop. So we have to be very careful about that. But the reason I bring that up is, what if the patient's very anxious and they cannot handle being awake while being intubated? You all are going to have to give them pain relief and sedation so that they can tolerate this. What if you accidentally knock out their drive to breathe? Because you know all narcotics in a high enough amount can knock out the respiratory drive. What if that happens when they're on a vent in assist control? No big deal. Okay, we've got that covered. But you, as the nurse at the bedside, you need to look at your modes and you need to somewhat understand what's going on, because if you're giving high levels of sedation, high levels of narcotics that could decrease or knock out the respiratory drive, you want to be sure that the therapist has this ventilator set in a way that they can fully support that patient's needs. Okay? So now I'm going to talk about some other modes of mechanical ventilation you're going to see. Let me do a quick little switch here. Another mode that you are going to see is SIMV. So I'm going to put this person into SIMV. SIMV is synchronous, intermittent, mandatory ventilation. So what does that mean? That means right now I'm set on a respiratory rate of 12. This vent is going to deliver at least 12 breaths per minute at the prescribed tidal volume of 560. However, the patient is now allowed, the vent will recognize their respiratory effort, and it will allow the patient to take a breath however they want to do it. So if they're still weak, they're allowed to take a spontaneous breath. That spontaneous breath may not be deep enough to take care of their ventilatory demands. So this is where you need to be aware, my nursing friends. And someday we may work together. Who knows? Watch your ventilator, okay? If I, as the therapist, am weaning this patient and I've weaned them down to a respiratory rate of 4 on SIMV, and you're unaware, and that patient's saying, I'm in pain, and they rate their pain maybe a 9 out of 10, more than likely you're going to want to go ahead and give that narcotic. Now here's where it gets to be a slippery slope. What if you knock out the drive to breathe now? How many breaths is this patient guaranteed? 4. That's probably not going to be enough to be effective for meeting their metabolic demands in most people. Does that make sense to you all? Okay, very good. So the next mode I want to talk to you about is something called Cpap. Have you guys heard of Cpap before? Okay, you can do non-invasive Cpap through a mask, or we can do Cpap as a mode via mechanical ventilation. Cpap is a completely spontaneously breathing mode. That means this machine is only giving one pressure continuously. The patient must be able to take a breath in and out. They must be able to maintain their own tidal volume. Okay? Now this vent's going to alarm because, well, my patient is not going to breathe, obviously. Okay? So, to do Cpap on its own, without combining it with another mode in mechanical ventilation, you must have a patient who has an intact respiratory drive, who can maintain their own minute ventilation. And you as the nurse need to be very aware that your ability to comfort and to pull into a different class of medications to maybe help them deal with anxiety is going to be essential. If you approach this patient who is in a weaning process the same way as you did the patient on full ventilatory support with assist control, and you give them high levels of sedation, high levels of narcotics, you're going to knock out their respiratory drive. That's going to be significant. Now let me tell you, all mechanical ventilators have this wonderful thing called backup apnea ventilation, and the therapist said it. So that if the patient does not take a breath for 30 seconds, this machine is going to alarm. There is on all mechanical ventilation, or all mechanical ventilators, there is going to be lights lighting up, and there will be audible alarms. Okay? So if that happens, the machine will alarm, and the therapist has set preset settings that if that patient doesn't breathe, we're going to pick up and breathe for them. But the machine is going to continue to alarm because it needs your attention or it needs the therapist's attention. Because it's now telling you, hey, this patient's not breathing anymore. They probably need your attention. So I don't want you to think that they will go completely apneic and not receive any ventilation. But I do want you to know that if you see that apnea ventilation alarm, and all of the vents have it, that patient needs your attention, and they need it quickly. Okay? Questions so far over the modes? Some of the indications? Yes.
So if we have them in the Simv and we're going to give them a high dose of a narcotic, do you then switch them to the AC, or do you wait to see if the backup will?
That's a very good question. Could those of you on the other side of the room hear her question? Okay. Her question was, and I'm going to try to paraphrase, correct me if I'm wrong, that if you have a patient who is in SIMV and they need the high dose of narcotic, which could knock out their respiratory drive, and you know you need to give it, do you need to switch them back to assist control, or do you depend on the backup ventilation through apnea to take care of it? And that's a very good question. What you need to do is talk to your therapist and see if it is possible to increase the patient's mandatory rate on SIMV. Because if you knock out their ability to breathe, okay, they're not going to take a spontaneous breath. If I increase my respiratory rate up to the 12 to 20 range, the machine is going to do that 12 to 20 breaths per minute. Okay, so the answer would be more of you could still give it if you had to, but you may want to consider talking to your other team members to see if the physicians put the patient on a protocol where you can up the respiratory rate. Okay? Yes?
So with this, it's like a collaborative thing, to where like the doctor orders the pain medicine, and then we'll give it, and if something happens, or like with the pain medicines, any pain medicine, if they're on ventilation, do we need to talk to the therapist anyways to see how they're doing?
You don't have to. I encourage communication, okay, in between team members, especially on critical care, because we have multiple disciplines working together for a reason. We've got the sickest of the sick, and just putting more eyes on them and collaborating has been proven to help their outcomes. You will generally, on critical care, and Marcia may have to help me a little bit, but what I know of critical care is that generally the nursing staff is given a titrate order for their narcotics to relieve pain or to titrate for a given level of sedation. Okay, so it is very important when you are giving those meds to be in communication. It may be even if it's just a, hey, Mr. Jones in room 12, I've got to up his propofol. He's not tolerating this well. I'm not sure what your vent settings are, but this is a move I need to make. Okay, and that will give the therapist an opportunity to go, oh, hey, hold it. He needs to go through this because the doctor wants him weaned off by 5 p.m. Okay, so it just is a good collaboration. Other questions? You guys have some really good questions so far. Yes.
Okay, my question is, are we allowed to change the settings on the ventilator without like a physician's order or talking to you all? I mean, is that...
Okay, the technical answer is none of us are allowed to change vent settings without a physician's order. However, what you see in healthcare quite frequently, and it is perfectly legal and perfectly normal, is most physicians will allow the therapist to work off of a protocol. Okay, and you guys are familiar with protocols? Okay, so there will be multiple ventilator changes without having the physician at the bedside for all of them. In some places, nursing will be responsible for some vent changes. Okay, it's going to depend on the facility.
Okay.
Other questions? Yes.
You're talking about weaning them off so that they don't become ventilator dependent. Is there a way that you can tell they're becoming dependent on it, like without taking them off and they're just not breathing?
Yes. Yes, there is a very specific process to weaning from mechanical ventilation. Okay, first thing you need to know is, why did my patient get mechanically ventilated? And then we look for, is that reason corrected? And then we begin a process of weaning them. It will depend on the reason they were intubated. Let's say, for example, a very healthy individual goes in, I don't know, they have a very unfortunate trauma, they have to have some surgery, they get out of the OR at 10 o'clock at night and they've had heavy sedation. Oftentimes, we will maintain them on mechanical ventilation on a critical care unit overnight to give the sedation from the OR time to leave the system. In that case, the patient doesn't have any pulmonary issues, and so we could actually turn the vent down to a spontaneously breathing mode and see if they will pick up their minute ventilation. More of what you see with ventilator dependence is going to be related to patients who have advanced lung disease, and that's why it's very important. Most therapists will do trials with giving them less support and seeing if they are going to respond. There's actually a process of somewhat retraining their ventilatory muscles so that they can take their work of breathing. So we don't know the exact moment if they are becoming ventilator dependent, but we do frequent checks. So we have a pretty good idea if they are going to be able to successfully wean.
If they never do, like if they can't pick up their own respirations again, like what do y'all do?
It's really pretty advanced. There's a series of diagnostic tests that can be done, and there is an extended weaning process. You can even take somebody home on mechanical ventilation. I used to work in home care, and I think my youngest kid was 18 months at home on mechanical ventilation, and then I had, of course, geriatric patients. So you have acute care patients. If they cannot wean there, they generally go to a subacute care where they get more one-on-one time and more of the focus is on rehabilitation and weaning. So there are multiple levels of care for the intubated patient. Anybody else? Yes?
So what would you do like head trauma or C3, C4 trauma where it knocks out the respiration and it's going to be a while before they heal? They're going to be pretty dependent on it.
His question, I don't know if you all could hear it over here, but head trauma, C3, C4 specifically, where it could knock out the ventilatory drive. You can have someone be ventilator dependent the rest of their life. Now, if you have hope of the spinal column healing, then you can actually trach them, and they can be on a lesser level of ventilatory support that will help retrain their muscles. So we start them out on full ventilatory support until we get them stable, and then as the patient becomes more stable and they need to progress to the rehab portion of their care, then we can change the ventilator setting to focus more on, are we going to get any muscle strength back? Particularly with the injuries you were talking about. You know, sometimes you have to look at, is this patient going to be quadriplegic? And if they are, they may need mechanical ventilation continuously. And patients can go home and they can live lives on mechanical ventilators. Have any of you all, or did any of you all see Christopher Reeves? Gosh, I wanted to be his therapist. Every time I saw him on TV, I was obsessed with looking at his trach. That man had like the best looking trach in the world.
Only a respiratory therapist would say that.
It's a respiratory thing. I was like, wow, look at the trach. But he went on TV, and they put his vent underneath his chair. And there are speaking valves that can go on. So you can deal with that. Your goal is to try to have them regain as much muscle strength as they can as their injury heals. Did that answer your question? Okay. Anybody else? You guys have some really good questions. Okay. So the next thing I want to go over, we've talked about our modes, okay? We've talked about our FiO2. What I want to get to next is, if you are the bedside nurse on CCUs, there are some things you need to be aware of. Okay. First and foremost, what you need to know is when you are moving, one of the biggest things any therapist is going to tell you, please be aware of the endotracheal tube when you move your intubated patient. Okay. You guys have a lot that you have to keep up with on CCUs. Okay. You've got CVPs and Swangans and Foley catheters and, you know, all of these other tubes you must keep up with. I ask you to really know where your patient's endotracheal tube is, because long story short, that one comes out and it's going to get real ugly real fast, because not breathing is a bad thing. Okay? So, you can, I don't know if Marcia can zoom in so you can see. But this endotracheal tube has tube markings. Okay, so this patient is at a 21 at the lip. So when you come on shift, there's going to be tape, and you need to look at it and say, okay, it's about 21. Because what can happen when you try to roll this patient is this tube can slip out, it can be pushed in, and that can affect whether the tube is in the right mainstem bronchus or if it comes above the vocal cords. If it comes above the vocal cords and we lose it, we don't have a way to ventilate that patient without reintubation. Okay? So know the position of your endotracheal tube. If you are working on a critical care unit that has therapists that stay on the unit with you, I encourage you, you're probably going to need an extra set of hands. Talk to your therapist. Hey, I need to change this bed. Do you mind to come help me? Let them come help you. We generally joke as respiratory therapists, hey, we like to be diaphragming up. That's kind of why we do what we do. Okay? But you know what? I help nurses change beds and do procedures all the time. I generally get up toward the head of the bed and I'll hold that tube for you and help move that patient and make it easier on you to do what you need to do. We've got to make this a team effort, a group effort. Okay? So know where your endotracheal tube is. You need to know a few common alarms. Anytime you have, for example, right now we have a low minute ventilation, or low VE, which is minute ventilation. Anytime you see low, think leak. Low, think leak. You have to have some sort of leak if you have a low tidal volume, low minute ventilation alarm or low peak pressure. So low leak. And it's really not complex as to how we're going to find the leak. We always start at the level closest to the patient. And to demonstrate this, Marsha, I'm going to have your camera move. Okay, so I'm going to have to put my hands and my face near this patient. And you guys are going to think I'm crazy. But I need to feel for a leak. And I need to listen for a leak. And sometimes leaks are very small. This vent can pick up small leaks. So you need to start at the level of the patient, put your head down here, listen, and feel and tighten every connection on the ventilator circuit all the way back to the machine. Okay? So that is what you will commonly start to do when you have a low tidal volume, low peak pressure alarm. Okay? Low, look for leaks. One of the most common is going to be that the cuff on your endotracheal tube has gone down. Your intubated patient should not be able to talk to you. You do not want to hear their sweet voice unless you intended the tube to be out. Okay? So if your patient sounds like they are gurgling or burping at you, or if they are able to go, "What are you doing?" Sounds creepy when I do it. It should be creepy when your patient does it if they're intubated. That means that your endotracheal tube has moved up above the cords, or your cuff is all the way down. Okay? So your patients shouldn't talk to you. They should not talk to you.
I have a question.
Certainly.
When I was supposed to see my patient had a strider, when they had taken it out and then they had to reinsert it because of the strider, is that caused from the ventilator or is it just?
No, generally the cause, there are multiple causes of stridor. Stridor in and of itself is a symptom of glottic edema. Okay? And everybody knows where the glottis is in the airway? The epiglottis, everybody remember? Okay. So the epiglottis, or the area below that, has swollen. One of the most common reasons for that is the patient may have been a difficult intubation. And oftentimes, if it takes multiple attempts at that intubation, then you have swelling in the airway.
I wonder because they took it out and she couldn't breathe because of the strider, so they had to re-intubate it, and so it made it even worse.
Yeah.
So she was going to be on it for like 3 or 4 weeks longer than what they expected her to be. So I wonder what caused stridor.
Yeah, oftentimes they may have been a difficult intubation, or if they are a patient, some patients are more anxious on mechanical ventilation. If you have a person who thrashes their head about quite a bit, the endotracheal tube will begin to move and rub against the vocal cords and in the glottic area, and just over the course of time it swells.
Tina, about 5 more minutes.
Okay, yes.
I want to stay.
What causes, like, once you got your patient intubated, you know how to go to the call, and it's just that loud, I don't know, it's kind of a real hoarse kind of sound when they try and cough.
When they're intubated, okay, her question was, when the patient is intubated, what causes their cough to be more coarse and loud? Okay. Generally, the reason if you're hearing it, if they're on a vent, is because it's very magnified coming through this tube into these corrugated tubes. Okay, so those act like a sound magnifier, I ought to say, and it makes it very loud. The other issue is you are introducing positive pressure into the lung, so that creates greater lung recoil. So kind of that cough has more pressure behind it. Okay, Marcia tells me I have 5 minutes, and there are just a few more essential things I need to get to. I apologize that I haven't been able to get through everything just yet. But one of the biggest things I wanted you to know was about a leak. Also, if you are seeing, let me see if I can make it happen quickly. trying to block his airway. Poor guy. It's all in the name of science.
And so we'll finish up while she's trying to block his airway in the next 5 minutes. Then if you want to stay, I know some of you have to leave. If you want to stay, then you can ask more questions. But let her get through her formal presentation, and then we'll field questions after.
His airway is not going to behave for me and be blocked. So, the big thing you need to know, if you have a high peak pressure alarm, the most common reason for a high peak pressure alarm is that your patient is coughing. High peak pressure alarms, your first intervention needs to be to drop a suction catheter. Okay? Oftentimes, if they are coughing, they've got mucus built up that needs to be removed, or their airway is obstructed. I instruct people to drop their suction catheter, which is what I have done to block his airway. His suction catheter is completely in his endotracheal tube. Because here's what this tells me really quick, okay? There are multiple things that could cause a problem with this airway, that could cause the high peak pressure alarm. My tube could have slipped, their compliance could have changed, they could have mucus building up, they could be biting their tube, okay? That's just a few of the things. When I drop a suction catheter, guess what I'm learning? Okay, I've got a patent tube, so they're not biting it. I apply suction and I come out and I see, do I have secretions and are they thick? In one big movement, I take away two of the most common causes. So that's why I encourage people to do that. And also while I'm down here, I can check my endotracheal tube placement and make sure that it's still in the right spot. So you can do 2 to 3 things all at once with that one movement and hit what are the most common causes of high peak pressure alarms. Okay? My last thing I wanted to go over with you is the fact that the most important person in the critical care unit room is the patient. On critical care, we have hundreds and thousands of dollars worth of technology. It is all absolutely worthless if we lose our ability to focus on the patient and to assess the patient. I tell my own students this all the time. I tell it to any group that will listen to me. We are in healthcare because we treat patients. We don't treat monitors. Okay? You are in this probably because you are a compassionate person and you want to help these patients. So we use the monitors as tools to help us care for this patient. So when this vent is alarming, oftentimes when you are new on critical care, this vent's going to be alarming. The cardiac monitor is going to be alarming. Your IV pump might be alarming. That's really overwhelming. And I have seen it time and again, not just nurses, I've seen it with therapists. You go in there and you get overwhelmed, and the thing that has the loudest alarm gets your attention. With a mechanical ventilator, this thing costs about $45,000 to $55,000. It is a wonderful piece of technology. But once it's alarmed, it needs you, it needs the therapist to figure out what's going on. So if you can't figure out what's going on, you focus on your patient. You look at their color. You always go back to your basics. Assess that patient. Look at them. Are they anxious? What is their work of breathing? What is their heart rate? What is their color? You know what? This thing back behind me is a $50,000 squawking hunk of metal at that moment. It's useless. That patient is most important, and the next most important is you. So if you don't know what to do, don't focus on this piece of equipment. You focus on that patient, and you get this ambu bag. Costs probably $50, which is pretty cheap in healthcare. And you hook it to 100% O2, you disconnect from that vent, you ambu bag. What do you need to do now? Do what? Squeeze it? Yeah? You know, that's a good point, because that's just natural for me. But yes, you have to squeeze it. You know what you need to do? You need to breathe. Because oftentimes what happens is you forget to breathe. So if you need to breathe, your patient needs to breathe. You ambu bag them and you call for some help. On a critical care unit, you're never alone. But what is most important is you know how to stabilize that patient. It's not most important to me or to anyone else that you as the RN can run this vent better than anybody else. Pride has to go out the window. We have to maintain an airway and ventilate. As long as I can get oxygen in, I'm making them breathe, and if they're stable, that's all that matters, okay? So if all of this flies out of your head the first time you're on critical care, please remember, just assess your patient and bag them, okay? As long as your patient is okay, everything else can be dealt with. Does that make sense? Thank you all for listening to me. Have a good day.